Good morning, Dr. Joseph.
Good morning, Rogers. You can go ahead and present the case.
This is Mrs. X, a 40-year-old housewife, who presents with complaints of excessive weight gain for the past 8 months, weakness for the last 6 months, backache and generalized body ache for 5 months, and bleeding spots on the skin for the last 10 days.
All right, Rogers. Can you tell me more about the onset and progression of her weight gain?
Yes, doctor. She says she has been gaining weight progressively over the past 8 months despite eating a normal diet. The weight gain seems to be more around her abdomen, but her arms and legs are relatively thin.
Good. Any other associated symptoms with the weight gain?
She feels extremely weak and lethargic, and she mentioned that she sometimes struggles to stand from a seated position. She also has back pain and general body aches that get worse with activity but improve with rest.
Does she have any other complaints, like headaches or visual problems?
No, she denies any headaches or visual disturbances. Her bowel and bladder habits are also normal, and there is no history of cold intolerance or increased sleepiness.
What about her menstrual history?
She has had oligomenorrhea for about 6 months, but before that, her periods were regular.
And her past medical history? Any significant illnesses or surgeries?
No, she doesn't have any significant past illnesses or surgeries.
Has she ever been on any long-term steroid treatment?
No, doctor. She denies any history of steroid or alcohol use.
What did you find on the physical examination?
On general examination, she's obese, with more trinkle obesity compared to her limbs, which appear thinner. Her face is moon-like and plethoric, and she has some acne and hirsutism. I also noticed a buffalo hump at the root of her neck and some increased fat above the supraclavicular fossa. She has multiple pink striae on her abdomen and back. Her skin is thin and has several bruises.
What was her blood pressure and pulse rate?
Oh, I didn't check her blood pressure, but her pulse was around 90 per minute.
Rogers, always remember to check both. In this case, her blood pressure is actually elevated at 155/90ths mmHg, which is important in Cushing's syndrome. Let's move on to the systemic examination. How was her abdomen?
The abdomen was distended with pink striae, but there was no organomegaly. I didn't find any signs of ascites.
Good. Did you find any muscle weakness?
Yes, she had proximal muscle weakness, more marked in her lower limbs.
And the nervous system?
Her higher functions and cranial nerves were intact, reflexes were normal, and sensation was preserved.
Great. Based on the history and examination, what's your diagnosis?
I believe she has Cushing's syndrome, doctor.
That's correct. What would be your differential diagnoses?
Maybe simple obesity, hypothyroidism, and polycystic ovarian syndrome.
Yes, those are valid differentials. Don't forget about metabolic syndrome as well.
Right, metabolic syndrome.
Now, how would you confirm the diagnosis of Cushing's syndrome?
We could do a 24-hour urinary free cortisol measurement or an overnight dexamethasone suppression test.
Exactly. And once Cushing's syndrome is confirmed, how would you go about determining the cause?
We could measure serum ACTH levels. If ACTH is low, it suggests an adrenal cause, and if it's high, it could be due to a pituitary lesion or ectopic ACTH production.
Good. Just remember to perform further tests like imaging if necessary. All right, Rogers, that was a decent history presentation. Now, let me ask you some questions about Cushing's syndrome. First, what are the common differential diagnoses you'd consider in this patient?
The main differentials I would consider are simple obesity, hypothyroidism, metabolic syndrome, and maybe PCOS.
Good, but remember PCOS is more common in younger women. Given the patient's age of 40, PCOS is less likely. What tests would you perform to confirm Cushing's syndrome?
I would start with a 24-hour urinary free cortisol test and the overnight dexamethasone suppression test.
Yes, those are the initial tests. What happens if those tests are abnormal? What would you do next?
If they're abnormal, I would check serum cortisol levels in the morning and at midnight, and maybe a low-dose dexamethasone suppression test to confirm.
Correct. After confirmation, how would you localize the cause?
I would check serum ACTH levels. If ACTH is low, it's likely an adrenal cause, and if it's high, it could be a pituitary lesion or ectopic ACTH syndrome.
Exactly. And if ACTH is high, how would you differentiate between a pituitary and ectopic cause?
I would perform a high-dose dexamethasone suppression test. If cortisol suppresses, it's likely a pituitary cause, and if it doesn't, it's probably ectopic.
Yes, that's one option. The corticotropin-releasing hormone (CRH) test can also help differentiate. Now, why do we use dexamethasone in the suppression test instead of other steroids?
Because, dexamethasone doesn't interfere with the cortisol measurements in the test.
Exactly. It doesn't cross-react in the radioimmunoassay for cortisol. Other steroids might. Now, why might this patient complain of back pain?
I think it could be due to the weight gain.
Weight gain contributes, but the back pain is primarily due to osteoporosis caused by prolonged glucocorticoid excess, leading to vertebral collapse. Be sure to mention that.
Got it.
Good. Now, can you tell me the treatment options for Cushing's syndrome?
If it's Cushing's disease, I would recommend transphenoidal removal of the pituitary microadenoma. For adrenal tumors, surgery would be the treatment, and for ectopic ACTH, I would try to remove the primary lesion if possible.
Correct. Don't forget, if surgery isn't possible, medications like ketoconazole or metyrapone can be used to inhibit cortisol production. Overall, good job, Rogers, but make sure to refine those details.